Welcome and thank you for standing by. At this time, all participants are in listen-only mode. To ask a question during question and answer session, press star then one, please. Today's conference is being recorded. If there are any objections, you may disconnect at this time. I would now like to turn the meeting over to Dr. Jakiba Henderson from CDC. You may begin.
Good afternoon. My name is Jakiba Henderson, and I'm an obstetrician gynecologist and a medical epidemiologist in the Division of Reproductive Health at the Centers for Disease Control and Prevention. I lead the state-based Perinatal Quality Collaborative activities here at CDC, and I'd like to welcome you to the 5th presentation in a series of webinars we are sponsoring on Perinatal Quality Collaboratives. Today's presentation is about Obstetric Quality Improvement Initiatives. And this webcast will include a discussion of examples of obstetric quality improvement projects undertaken by Perinatal Quality Collaboratives, including project challenges and successes, statewide dissemination, and the role of system design in achieving significant and sustained improvement. Our presenters today are Drs. Peter Sharoni and Jay Iams. Peter Sharoni is currently Emeritus Professor of Obstetrics, Gynecology, and Reproductive Sciences at the University of Vermont College of Medicine. He has a strong clinical interest in obstetric healthcare quality improvement and is currently serving as chair of the Institute for Healthcare Improvement's Perinatal Improvement Community since its founding in 2004. In this role, he is responsible for developing the Obstetric Quality Improvement curriculum with the faculty and serves as a medical content expert. He was the lead author of the Institute for Healthcare Improvement's white paper entitled Idealized Design of Perinatal Care. He is also currently the medical content expert and obstetric quality improvement consultant for the New York State Perinatal Quality Collaborative. Other recent research and work in obstetric quality improvement includes acting as chair of the March of Dimes Collaborative entitled Improving Prenatal Care in Vermont, and as co-investigator of the Med Teams Project. Our second speaker is Jay Iams, who holds the Frederick P. Zuspan Endowed Chair at The Ohio State University, where he is professor and vice chair of the Department of Obstetrics and Gynecology. He has conducted clinical research in prematurity since 1982, including trials of risk scoring and patient education, outpatient uterine contraction monitoring, and antibiotics to prevent preterm birth. Dr. Iams has been the principal investigator at Ohio State in the NICHD Maternal Fetal Medicine Research Network since 1992, and he is the associate editor of the American Journal of Obstetrics and Gynecology. He served on the National Academy of Science Institute of Medicine Committee on Understanding Preterm Birth and co-authored the committee's report issued in 2006. Dr. Iams also serves as the obstetric clinical chair for the Ohio Perinatal Quality Collaborative. At the end of this presentation, there will be a question and answer session when you will have the opportunity to ask questions and participate in the discussion. This presentation will also be archived on our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC. I will now turn the presentation over to Peter Sharoni and Jay Iams.
Thank you, Dr. Henderson, and good afternoon to everyone. I certainly appreciate the opportunity to present the work we've been doing through the Institute of Healthcare Improvement Perinatal Community this afternoon. Due to the brevity of the time, we're trying to get the information across in the next 20 to 30 minutes. I hope you take advantage of the archived presentations if you want to go into some of this in a little more depth. I do have nothing to declare. So let's go ahead and move ahead. It's reasonable to define what a collaborative is. For those of you who have not participated within a community or a collaborative, it's through the Institute of Healthcare Improvement. It's based on the IHI Breakthrough Series model, and it's an intensive frontline improvement process of work within these collaboratives that take a year. So we've rolled ours over, as you'll see, about 10 times now since we started in 2004. And it's clearly designed for organizations with the commitment of moving ahead and moving towards sustainable change. And our topic area, of course, is perinatal improvement and quality improvement. I'll touch on the history. We'll look at some of the drivers that led us to do this, the curriculum that we've developed over time, and finally the measurement strategy, and really just briefly touch on some results that we have seen through the community efforts. We did start actually in 2003 where we were asked through IHI by some hospitals who had some significant perinatal sentinel events and wanted to move forward with quality improvement. That eventually led to the perinatal community starting in 2004. And what we found in our initial work was significant unexplained variation within the system of care. We saw that our systems are highly complex and that the majority of errors, approximately 90%, are actually system-driven. There are still some individual issues, but the vast majority of patient-level errors are system-driven, about 90%. Communication failures continued to drive patient risk as well, as the Joint Commission began publishing on this in 2004. And finally, we really wanted to drive toward a method of prospective quality assessment. Since JCAHO was incorporated back in 1951, the drive was to look at individual events, which was by nature always after the fact. We really wanted to design, as we've seen in industry, as we've seen in airlines, means to identify potential risks and mitigate their effects at the patient level on a prospective basis. So that's the initial history. As far as participation, we generally ran between 45 and 70 hospital teams a year. We currently have 63. A group within the Louisiana Hospital Association HENWORK, or Hospital Engagement Network, began in 2000 and 2004 and 2005 with the Premier and Ascension Health Group when we initially developed the concept of clinical bundles and oxytocin bundles from the IHI work, and then moved on from 2006 to date with the Impact Learning Community. Through that, we developed means of looking at, in-depth, at a hospital evaluation where they are currently and where they need to move forward. We went beyond, actually, at this point, the oxytocin bundles to advanced bundles, and also looked at some what we thought were fairly straightforward things, so we started looking at it, like the concept of reliability around establishment of gestational age. And then I mentioned over the last 1.5 to 2 years now, the Louisiana State effort, which was initiated by their Department of Health and Human Services, initially supporting 40 hospitals. What they found is they're actually supporting about 70% of the deliveries through their Medicaid system. So they had a keen interest in improving quality and controlling costs. The drivers for our need for quality improvement, historically we took a 10,000-foot view and then we did some views on the ground. The 10,000-foot view is in the 1950s. We had a limited amount of sophistication in our medical care, pretty clearly. That's developed markedly over the last 50 to 60 years, particularly around obstetric care, both maternal and neonatal care. And we've seen a substantial drop in what we might term the non-preventable injury. Things like ROGAM, improvement in our assessment of mothers and fetuses and infants have certainly driven toward a markedly reduced perinatal as well as maternal morbidity and mortality over time. And if we flash up to 2007, when Frank Mazza published his information out of Ascension Health, which included multiple areas of quality improvement, including some which we worked with him through IHI, they found where our estimate when we came into this was about half of perinatal sentinel events of birth injury would be preventable. They actually saw a 90% drop. So importantly, the preventable part of the ledger, if you will, became a very important part of the total injury. In fact, our systems were causing more harm than our medical care, and this has been found to be fairly true throughout medicine in general. So the systems-driven error were substantial. JACO initially published on perinatal sentinel events in 2004, and as I mentioned, 70 or more % of all perinatal sentinel events had their initial driver as a communication issue. So there are also things that we didn't always consider on the clinical side that we saw that we had to move and improve on. So many challenges, our great challenges really surrounded making the systems of care work, which really meant changing the systems of care within which we work. Taking the concept of reliable design strategies, which means our policies are great. How do we make sure those policies get all the way to the patient bedside every time for every patient a given process happens? Again, the reliable design strategies, both taken from industry as well as other areas. Certainly improving communication was an important piece of that. As we continue to see, a high % of perinatal sentinel events are initially driven by information not getting where it's supposed to be when it's needed. Standardizing what is standardizable, and this is an important concept that limits what we standardize because some things cannot be standardized. We recognize that early, but we could also sit down and talk about, for instance, we know there's multiple Pitocin protocols out there and they're all within standard of care, but for the vast majority of patients, could we agree on one? Next, simplifying where appropriate, and again, that would be an example of that as well, but not oversimplification because that can lead to its own issues. And just as importantly, we found significant unexplained variation in our data when we looked at different hospitals, and we wanted to work toward eliminating that. An example of that might be within the same basic demographic population, we saw a 5-fold difference in induction rates and a 7-fold difference in operative vaginal delivery rates. So we felt that likely represented unexplained variability around the concepts of care. And that drove us towards the idealized design of perinatal care, which, again, somewhat redundantly, taking our systems and develop reliable clinical processes in all the different processes we do on our labor and delivery suite. Use principles that improve safety, both from designing our systems so that they initially prevent an error from occurring, but also making them redundant so that errors can be detected and the effect on the patient can be mitigated. Certainly work towards standardizing communication in our care teams so that communication is effective both with each other and with our patients and their families, and shift the focus toward the mother and the family as the control point during labor and delivery. When we first started developing our driver diagrams, we began, as they often do, with some skeletons, looking at key outcome and process measures, and then moving toward the right with the 4 main drivers of perinatal leadership, reliable processes, effective teamwork, peer teamwork, and respectful patient relationships. And then breaking out what needs to happen for each of those to be successful. Now, I'm going to go through the next 4 slides fairly quickly. You'll just see how this continues to branch out, and then we'll move into how we then developed our key drivers from there so it's workable at a hospital level. So you can see from perinatal leadership standpoint, that breaks out as it does under reliable processes, looking at things like standardization, being careful of overuse and underuse as well as misuse of our resources and assets, regarding effective peer teamwork, standardizing communication when appropriate would be one example, and finally respectful patient partnership, transparent communication, and other issues. So again, feel free to this is recorded so you can go through these at your leisure to understand them better. But let's flesh some of that out when we look at our curriculum as we developed it through the years. And again, on a full driver diagram standpoint, we can see now the specific roles and tasks that were rolled out from each of those that we just looked at in brief, with the concept and the goals of reducing harm to less than 5 per 100 live births, decreasing the incidence of elective deliveries prior to confirmation of fetal maturity. And actually, when we read that and we say elective deliveries prior to confirmation of fetal maturity, notice we didn't say 39 or greater weeks here or there at this point, and I'll mention that in a minute, that really should be 0. That the augmentation bundle composite, and we'll explain bundles in a moment, should be greater than 90% for each hospital unit, and that we work on improving organizational culture and full participation in the labor and delivery teams as they document patient and family-centered care. On the right side, you can go down and see the individual goals and tasks that can be picked up. They aren't, importantly, you can't work on everything all at once, that you do need to focus down on that, and that's what we developed the curriculum to do. You need to focus down on individual pieces. And this is when the building blocks came into use for the different hospital units. You can see where they can look at this and see just how they can move through the perinatal improvement curriculum. Generally, the first 3 months is even the pre-work, what we call the deep dive pre-work, which gets an evaluation of the hospital at the present time, or of the labor and delivery processes at the present time, so that you can identify things to work on immediately before you begin the particular curriculum around the perinatal oxytocin bundles, as I'll mention, the more advanced bundles, and some of the measurement strategies around perinatal harm, particularly around the perinatal trigger tool. And then as months go on, as you can see going up the building block diagram, all kinds of quality improvement steps to take, whether it's establishing huddles and multidisciplinary rounds in the 3rd tier, or just making sure all your documentation, including the tools you use on labor and delivery, use the 2008 NICHD language for a common external fetal monitoring language, and that training is multidisciplinary and the same for everybody. As far as the deep dive goes, what the deep dive is it's a tool that allows a hospital to find out, a labor and delivery unit to find out where they currently are now. Again, as we walk into most hospitals and say, let's see your policies, generally all the policies are completely compliant with the A1 and ACOG current guidelines and are completely up to date. The problem is the systems we develop to get those policies to the patient bedside are the issue. So what the deep dive does, it allows a deep evaluation of the care practices that are currently happening on labor and delivery so that the unit can understand where they may be lacking. Importantly, it's a random sampling of a certain number of charts to get a statistical, to get enough of a statistical number so you get a sense of what's going on, and not just on the day shift, across providers. This should be across providers, across all days of the week, across all shifts. And it does focus on structure and process measures. Again, we were driven from the Avis-Donabedian model, structure, process, and outcome, with a significant focus on structure and process initially. It's not that we don't look at outcome. We've been looking at outcomes for 50 years, whether it's C-section rates or pick any one of them. But the key is if you, and this is my engineering background coming out, if you really focus on structure and process, in a way, the outcomes take care of themselves. If you get that all right, that is. The next step is the clinical bundles, and for those of you not familiar with a clinical bundle, what they are is a group of clinical events that all the providers agree that should happen for every patient, every time a given process occurs, whether that be an induction, an augmentation of labor, a vacuum-assisted delivery, a cesarean section. You can structure a clinical bundle. Again, the concept from IHI is that each component of that bundle should happen for every patient of every time. In short, you don't get partial credit unless you do the whole bundle. Each individual element is agreed upon, and it's built on the science we have in our field. And as I mentioned a moment ago, the emphasis is on process. We aren't ignoring outcomes. Certainly, you have to do outcome evaluation, but this is all process-oriented initially as far as the clinical bundle goes. In 1984, we developed the oxytocin bundles, which have now matured into the advanced elective induction advanced indicated induction, and advanced augmentation bundles. I wanted to put this up as our first bundle because, as you can see, the top line, what it says is confirmation of fetal maturity. We didn't write it as 39 or greater weeks. So the 39 rule, which has really permeated our vocabulary, is really a shorthand way of saying confirmation of fetal maturity as outlined by ACOG guidelines really since the 1970s, as translated to be 39 or more, 39 completed weeks or greater. Over the last 4 or 5 years, we've had substantial data that's actually continued to support that concept, and a discussion in the literature, and really an adoption of a language of early term and later term, meaning 37 to 38 6, and then 39 weeks and later. So not surprisingly, this morphed into the gestational age of greater than equal to 39 weeks, completed weeks. But very importantly, again, it's much easier to have a discussion around have you confirmed fetal maturity than it is to have a discussion around is she 39 weeks? Well, she's 38 6, and in 6 hours she'll be 39, and then you get into all those nuances. And we're not talking about amniocentesis. That's fetal lung maturity. We're talking about confirming fetal maturity by current ACOG and data guidelines. As far as the augmentation bundle, again, at the same time, these are the drivers that our professional organizations, particularly ACOG guidelines for perinatal care, should be in place if we're moving ahead with augmentation. And that's how the clinical bundle was developed. We also saw significant perinatal harm around particularly the use of vacuum, as well as forceps, but we did develop a vacuum bundle fairly early on for that same reason. Just to have individuals focus in on the care they provide at the time. One surprising issue, of course, if we're talking 39 completed weeks, and inherent in what we do in obstetrics is gestational age calculation, is we found a significant variation around gestational age. So we did develop a gestational age reliability tool. We've actually rolled one out, which I tried to conclude as a PDF in this presentation, but it didn't work out. We developed one with the childbirth education, with childbirth connection, and the perinatal community to roll this out actually to patients, and it is aware to them as well. But the errors we generally found in gestational age assessment was the most common error was confirmation of not ideal menstrual dating. In other words, an ultrasound was done. It was felt to be close enough, even though the patient didn't really know her dates or couldn't give you an accurate assessment. It was used anyway. And certainly in those rules, in those situations, the ultrasound is the better assessor of that gestational age. We also saw inconsistent documentation and sometimes not locking in a given gestational age till the patient was at term, and not maliciously, but a date was chosen, so to speak, whether the ultrasound or the menstrual dates were chosen to sort of confirm what we already knew, that the patient was going to induction or whatever it might be. One of the many tools, lighthearted tools we use through IHI, we call it the Ask 5 People rule. And that's if you think you have a reliable process, go ahead and ask 5 people how they do it. And if all 5 give you the same answer, then you have a reliable process. We find consistently, whether it's asking people how they determine gestational age in a given clinical circumstance, how they run an induction, how they run an augmentation, we find we consistently get multiple answers, which tells us on the ground that there is not reliability in those processes. The trigger tool was developed as an adverse drug event tool through IHI, and we adapted it in the perinatal community as a perinatal trigger tool. It fairly easily does identify events without complex technology. It's easy to review charts to do this. It is easily integrated into any good sampling methodology you're already doing for data points. It's not particularly, it can be used somewhat with administrative data sets. That's a downside of it for sure. Generally, it really needs to go to the chart, a completed chart to evaluate the structure and process measures from the trigger tool. And of course, the changes, it importantly changes the discussion away from data for punishment towards data for improvement. And the reason it does that is because it changes the discussion away from provider errors to patient harm. It also moves away from the discussion about preventability, We don't want individuals trying to decide on the floor if a given untoward event is preventable or not. As we found from Dr. Maz's information earlier, and many areas across OB care, if your concept of preventability is broad enough, many things fall into the preventable category. So we don't want to try to make that distinction too early on. This is the perinatal trigger tool, and you can see there's a number of triggers, which only mean you look more intensely at that chart and see what the cause of it was. It does not imply that an error occurred. It does not imply an adverse event. An important concept of the trigger tool is just that. A trigger does not mean that there was an adverse event, although most adverse events, if not all, can be equated with harm. And you can measure that over time. Some of our advanced teams who've been with us for several years now are moving to the more advanced team concept around the Joint Commission PCO2 measure, which is the nulliparous primary cesarean section, term cephalic singleton. And as we've seen from the NICHD maternal fetal medicine group, I believe it was the November publication in the Green Journal, where they had a consensus meeting looking at some of these definitions, and we found where a good deal of variation occurs, as Elliot Bain has shown us in that singleton primary cesarean section measure, that a good deal of variation is driven by the number of inductions that are done in this group and when patients are admitted for labor. So we've challenged our groups, just as the NICHD working group has done, to work toward defining labor and use some general admission criteria. Again, not for every patient is this going to work. Finally, defining induction and augmentation, we find there's a variability in which patients are induced. Let me take that back. I apologize. Which patients, how we define induction versus augmentation. And we most importantly need to have consistency so we have good data. For instance, there isn't always agreement on a patient who's ruptured at 2 centimeters minimal contractile activity, whether she's having an induction or augmentation when, for instance, Pitocin may be started. And finally, the whole concept around defining when arrested progress occurs in active labor or induction has been unsuccessful. And that's the discussion we're continuing to see broadened out in the literature around our more contemporary assessment of labor patterns. And finally, just touching on the measurement strategy and the results as we work toward the measurement strategy, as I've mentioned in the bottom of the slide, reducing the harm to 5 or less per 100 births, essentially 0 incidence of elective deliveries prior to confirmation of fetal maturity, augmentation or bundle composite, and we can measure that, improving organization culture, and documentation of patient and family care through the 4 drivers. This is our measurement strategy in tabular form. You can see the Joint Commission PCO 1 and 2 are in the middle in the gray, and the Joint Commission 3, 4, and 5 are currently in the optional measures up on the right side in the light gray. We also encourage patients to do some of the optional measures. We strongly encourage, for instance, we find gestational age reliability is an important component of the evaluation of just about any of the other things that are done. You can see there's both a biannual and annual structural assessments as well as monthly and weekly evaluations that can be reported. And finally, results. Just briefly touching on some results so you can get an idea of what they look like when they're evaluated. This is our Louisiana cohort group when they started looking at their 39-week measure. We had some Louisiana cohort with us for some time. That's the top slide. That's why they're starting at a substantially lower rate of elective deliveries prior to 39 weeks. When we weight them all together on the bottom, including the hospital engagement network or the HEN group, when they came into the fold, you can see it's considerably higher, but they've also had a dramatic effect. I'd also add here that the Louisiana Department of Health and Human Services recently reported, and this is in a state that does 65,000 deliveries a year, that last year they had 50,000, that's 50,000 fewer nursery ICU admission days. That's probably translates into something around $30 to $40 million. When we look at augmentation and bundle compliance, this is what these graphs look like, and there's two important points here. One is on the left. Most hospitals' composite compliance starts in the 40 to 50% range, and there are fits and starts in their system and improvements until they find the system that works for them. And it's important that remember that each hospital is unique, each structure is unique, the people who work there are unique, and they have to focus in on the process that works best for them. And you can see they eventually hit on that, although it takes considerably longer than we would have thought when we started this. In fact, the two things the bundles also do, in addition to complying with care, that they also demand significant communication goes on between the providers across the labor and delivery unit. As far as the trigger tool data, it looks something like this. Over time, you like to see the incidence, the events of harm decrease, as we can see in this unique single hospital experience event. So just to sum up, with the IHI Perinatal Improvement community, starting out of the collaborative, recognized and has worked on, we know that systems are designed to get just the results that they achieve, so we knew we had to change the systems in the different hospitals in order to see significantly improved results. It's important to focus on structure and the process of care, because that's where the issues, first of all, they're easily measured, and we can have multiple parameters to measure them, and the use of reliable design strategies are the best way to consistently get the care at the bedside that we intended for the patient to have. The focus and complete emphasis on data for improvement, not data for punishment, and we continue to drive this in the Just Culture network so that providers don't begin to move away from providing the data. Finally, continuing to measure so you know where you start and you know where you are. And finally, the leadership and the ownership that has to happen on the ground at each individual hospital. We cannot come in as a perinatal collaborative and say, do this, do that, and leave and expect it to be consistent over time. There has to be leadership running the show on the ground in each individual unit, and it has to be owned locally. So thank you as I turn this over to Dr. Ian.
Before Dr. Iams presents, I just want to remind or let participants know that handouts of each presentation are available for download. If you click the white pages icon, the icon that looks like white pages at the top right corner of your screen, which is the handouts icon, you can download both presentations. I'll now pass this over to Dr. Iams.
Thank you, Kiva, and thank you, Peter. I'm not seeing my own slides up here.
I'll pull them up for you.
Okay. I think our two talks, although we didn't plan it this way, that's somewhere at the end, I guess, we didn't plan it this way, have actually dovetailed pretty nicely because as someone who trained in maternal fetal medicine and obstetrics and learned quality improvement literally on the job, from the work of Dr. Chiruni and IHI and Carol Lannon in particular, what we're going to show you is an example of how one state has adopted this and picked topics that are all around the issue of prematurity rather than an obstetrical safety and improved outcomes for an obstetrical unit. Our topic selection, as you'll see, is driven by the choice of prematurity-related adverse outcomes for the baby. So let me declare first I have only one conflict to report in that I am linked to the Elsevier Publishing Company through journal editing and book editing. Other than that, no significant conflicts. So if we can go to the next slide, we'll show you the overview, the backup one there, the overview of the Ohio Perinatal Quality Collaborative. We are a team of pediatricians who founded this and quickly added obstetricians to focus on the issue of prematurity. and we do contribute to one another's design and outcomes and goals. We have conducted parallel projects with a fair bit of input and commentary along the way. We haven't done a design together and an intervention together yet, but we're getting there. The boxes outlined in red here are the ones we're going to talk about today, primarily the 39-week scheduled deliveries and dissemination of that throughout the state, and a little bit about steroids, and then our plans for what we hope will be a successful progesterone project. You can see the neonatal projects there on the right side of the slide. One slide, next one is on the issue or the question of our structure and budget. We have been grant funded along the way from federal funds, matched by state funds or supplemented by state funds, and later from CDC, March of Dimes. A lot of in-kind support from various institutions, and you can see where that funding goes. We keep together around the state by weekly phone calls on multiple levels. We have a weekly leadership call. We have weekly project calls, sometimes twice weekly project calls as we get closer and closer to introducing something new. A monthly executive oversight of stakeholders who are interested in our work, trying to make sure we have regional balance. We have faculty from around the state. We try to make sure we have regional balance there also, and pay a lot of attention to rapid collection of data and turnaround, and particular attention to cooperating and collaborating with the Ohio Department of Health and its Vital Statistics Division with something called Beacon, which is a state funded quality improvement team of, in our case, two nurses who are devoted primarily to this type of project and who travel the state doing QI. Notably, we've had good support from professional organizations as well. So I want to tell you first about the 39-week project. We had a statewide project affected 20 hospitals. About half the births in Ohio are in the 20 largest hospitals, and this simply shows the results of that project based on the designs that IHI has advocated, with weekly phone calls introducing exactly the concepts that Peter was talking about. And you can see in the hand-collected data here that we had a drop from around 15% at the beginning to down below 5%, which met our goal. And of course, that success led the state to ask us to disseminate that to the rest of the state. Let's look on the next slide, and you'll see that we're also looking at our outcomes at the same time on birth certificate data. People always ask, well, that's not very good data. You're not really seeing what's really happening. But in fact, we are seeing what's happening to the data as it's traditionally been collected. This slide goes back to 2006, and you can see that what we did influenced not only our own data collection by data abstractors in each hospital, but it affected the rates that were shown in the birth certificate data, where we were not controlling how they did it. That comes a little bit later. Next slide. Here you can see the results over time. First of all, that the rates are lower to begin with and got lower in the pink line. Those are the OPQC participating large hospitals. You can see that the rest of the state got somewhat better. The non-OPQC hospitals had a higher rate to start with. So they were influenced indirectly not only by our project, but by other national and regional projects as well. We also modified our definition to bring it in line with what others were asking of our hospital sites. We started out looking at births that were scheduled between 36 and 0 and 38 and 6. That's inconsistent with JCO and Leapfrog and others, National Quality Forum, so we converted to match them. So that's the background. The little star there on the bottom right of the slide shows you there was a significant increase just recently in the rates in our hospitals, and we have had to pay attention to that, or we are paying attention to that. because that's what happens when you don't pay attention. Things get a little worse. Next slide. Now we'll talk about statewide dissemination. What we recognized from our first project was that the birth registry is really more than a certificate, more than a piece of paper, and Ohio is recognizing that by starting to call it the birth register rather than certificate. And it can be a quality improvement tool, and you can quality improve your improvement tool. So that was our first task, and we engaged the CDC and Ohio Department of Health to work on that. We used our initial larger sites as models and added sites in waves. We couldn't embrace all the other 95 Ohio maternity hospitals at once, but we rolled it out in waves to extend participation to the remaining Ohio maternity hospitals, doing it primarily as a geographic and also a payer mix. We wanted to do it in a balanced fashion. And in fact, we're still working on that right now. Next slide. We have the next one. There we go. The project started by recruiting with the support of ODH. Ohio hospital administrators listen when they get a letter from the Ohio Department of Health, so that was helpful. And we called the local leaders in these various hospitals, arranged site visits for our Beacon coordinators, our QI coordinators, to meet with them, for our Ohio Vital Statistics staff, the people who run the birth certificate data, going to face-to-face meetings with as many teams as they could, other staff from OPQC, and meeting on monthly webinars and in face-to-face learning sessions coming to Columbus. And then with individual coaching calls to individual sites if they had problems that they didn't care to discuss on a 15-member quality improvement call in our first pilot wave, for instance. One of the most pleasurable parts of this is learning how excited and enthusiastic our birth certificate registrars are at the local hospital. I think that's on the next slide. We did it in waves and started out in the first 15 sites and learned from them, and then we have subsequently rolled it out, and we're almost through starting the last wave. The birth registrars have been a neglected resource. I really had no idea, had not met the birth registrar at my own hospital where I've worked for 30, 40 years now, and did not know that those people, and did not appreciate how excited they could become when someone actually paid attention and put them in the same room with the people who generate the data, the nurses and the doctors. This is a different project from the initial charter group of 20 because we're solely using birth certificate data. So we're improving the tool while we're trying to improve the practice. And that's been an interesting process. Next slide shows, I think, two different key driver diagrams, one to improve the accuracy of the birth data, and the other a more traditional scheduled birth. We use the term scheduled to include all births that are for which an appointment is made. That includes some where the appointment is made appropriately for good reason, and others where it's made for non-medical reasons. And so we capture a broad net there and try to avoid the use of the word elective, which translates very often to unnecessary and should never have been done at all, where in fact sometimes electively timed births are the right thing for patients who have a particular problem that needs a group of people to look after the patient or her baby. Next slide. You can't really change the birth certificate. It's a national document. Various versions exist, and you can't go in and tinker with it. It has to stay the way it is, but you can change and improve the guide for the birth certificate worksheet. And that's, in fact, what we did. We asked the birth registrars who were having trouble filling out all the many boxes on the birth certificate to focus on key variables that mattered the most to public health and perinatal people. And we provided a new focus group set of tested definitions so that the most confusing of those key variables were more appropriately defined. Next slide. Here's our baker's dozen of list, and as Dr. Sharoni mentioned, obstetrical estimate of gestational age is certainly the most important. We decided we would pay attention also to two, one of them the steroid project that we were about to do, and another that precedes the progesterone project. We wanted to know about a history of a previous premature birth. This is not to say the other variables on the birth register are not important, but these are the ones we wanted our birth registrars to look at most closely and carefully. Next slide. One of the things that we discovered is exactly as you heard before, is that the inaccurate gestational age has a couple of causes, the most common of which are these two. Gestational age is frequently rounded up by people who haven't been educated otherwise, and the birthday analogy works pretty well to explain that. And then, as Peter said, the number of different places where the gestational age is recorded and the number of different pathways to those various gestational ages led us to promote processes that created consistent agreement about the location and the method of generating the most accurate obstetrical gestational estimate of age. Next. We want to put that data in the same place in the record, put accurate data in the record once and make sure that everybody agrees on that so that it's the best estimate and there is a single estimated delivery date in the medical record. And this is a work in progress, but we are seeing substantial improvement in concordance between hand-collected and birth registry data. Next slide. So we've made some progress. As I said, the birth registry staff is excited. We've had the major misunderstandings on definitions of preeclampsia, gestational age, recognition of what antenatal steroids are for, definitions of breastfeeding, and we've seen improvements in 10 of the 15 pilot sites, and we're seeing similar beginning improvements in the remaining waves that are still being rolled out. So next slide. This is the 15 smaller hospitals. Over time, you can see our initial project in the middle of the slide was associated with a decline in these hospitals that were not part of the project, and then there was further improvement in their rates as they began to participate in this project. Next slide. Steroids was an issue that we will just turn to briefly here because there was disagreement between the PEDS and OB folks in Ohio over how well we were doing. We certainly weren't documenting it very well, and the rates looked abysmal, actually. About 60 to 75% of babies were expected to have gotten steroids. So we did a prospective look over a period of about a year and looked at almost 2,800 infants born in the gestational age window. As you can see here, 90+% got at least one dose and 80% received a full course. There were about 8.5% that did not receive any dose of steroids, most of those delivered within 2 hours of arrival at the hospital. Next slide. You'll see the outcomes here were not really quality improved. They were this is hand-collected data here. They were above our target goal really as soon as we got our data collection system up and running. We've been above 90% pretty much ever since we started looking. Next slide shows you, however, the rates on birth certificate data where they were substantially less. They got somewhat better when the state announced that they were going to start publishing these and looking, but they still don't get anywhere close to the actual rate in hand-collected data. So we have a huge lag here in birth certificate registry documentation of steroid use in Ohio. Next slide, we're going to talk a little bit now about progesterone and why we picked it. It's the first opportunity we've had to have some kind of intervention that could potentially reduce not only premature birth, but infant mortality, because prematurity is one of the leading drivers of infant mortality. So these are our criteria, the OPQC criteria that you see here. It's prematurity related. There's variation. There finally are benchmarks from ACOG and SMFM. Measurable outcomes of interest are already being recorded by the state in rates of premature birth and infant mortality. We want, under Ed Donovan, our founding father's leadership, to move the population, move the numbers. And there's no question that if we can move infant mortality and prematurity that we would be successful. Prior success demonstrated somewhere else is one of our criteria. In this case, there has been prior success in randomized trials, but it's not clear that a population-based project has shown improvement. We have a lot of people who are very enthusiastic about this, but we are a little, we are entering it with a little trepidation because it hasn't been rolled out in the state or a region. Very many examples of that do not exist. So we are going to take the dive here pretty soon, we hope. Next slide. Our goal is to reduce the rates in Ohio by 10%. That was a long discussion, a little more accurate and fine-tuned goal. That's not quite 10%, it's more like 9-point-something%, and how we got there. And to do that, we want to expand the use of progesterone by recognizing the population at risk with a previous preterm birth, and we want to expand the use of cervical sonography and make it easy to get progesterone, get the insurance companies involved, and make sure that we have outcome measures that we can have some faith in addition to the primary rates, some process measures along the way of the number of women saying yes, number of what the barriers are in terms of insurance, things of that nature. The next slide. There are lots of obstacles about who should get which drug and when you can and can't. How should you find them? Should you do cervical ultrasound for everybody or some subgroup? Is there some other test? Who will pay for it? How can you write the prescription? Even just turning the decision to recommend progesterone into action takes a lot more encounters a lot more problems than you would ordinarily expect with any other medication. There's all the issues of the FDA approval and the private manufacturer and compounding pharmacies. And finally, it's a repetitive intervention, unlike things in labor and delivery where you make a decision and do it or don't do it. This is a decision that has to be repeated and often repeated by the patient throughout a period of several weeks, about 15 or 20 weeks. So that's an obstacle we haven't faced before. Next slide. Here is not our current key driver diagram. This is one that was back in September. We've been working on this for a couple of years, and we're up to version number 11 or 12. I'm not sure which one this is, but it's a pretty colored slide, so I decided to use this one instead of the less vividly colored recent one. But this is exactly the kind of diagram that Pete was talking about before, of an aim and a goal with drivers, and in this case secondary drivers and various interventions to approach this problem. Next. There are two pools of candidates for progesterone. One are women with a prior preterm birth, and that sounds pretty easy, but in fact it's prior spontaneous premature birth, and we've learned, at least in several of our metro areas, that an accelerated first appointment is advantageous because it takes you sometimes 3 or 4 weeks to figure out exactly what the records show about that. So having an appointment that isn't at 16 weeks when you're supposed to start progesterone, but that actually gives you a month or more of time to investigate the history is important. We created some criteria for defining a spontaneous preterm birth, which we could go into in the question session, but to be a little more specific than just spontaneous. Next slide talks about cervical length measurements. How do you identify women with a short cervix? In this case, we did pick a statewide threshold of 20 millimeters, which has emerged from the recent literature, and have recommended that sites choose an algorithm. They don't have to pick the same algorithm, but to pick either universal screening or screening aggressively and making a list of those women who might be eligible based on their history, or more recently, a more popular option may very well be to say, we're going to screen everybody except those who have a very low risk of having a short cervix, for instance, a multiparous woman who's had more than one previous delivery at term. We want each site to have algorithms for screening in general, for treatment and follow-up, and to embrace the notion that cervical ultrasound needs to be done by people who have achieved credentialing either from the SMFM, ACOG, AIUM group called CLEAR, or from the Fetal Medicine Foundation, either one. Next slide. Prescribing progesterone turns out to be, as I said, somewhat difficult. The local management protocol, and I think the most important line in the whole progesterone project is on the bottom here, make screening for prematurity risk a routine part of everyone's care so that everybody gets screened for RH status, everybody gets screened for group B strep, gestational diabetes, everybody gets offered a maternal serum screen for birth defects, and everybody should have a checkbox. Have you had your risk of prematurity assessed, and are you or are you not a progesterone candidate? Next slide. These are a couple of the next few slides, a couple of the protocols. You'll see various versions of the protocol here that are being put forth around the country. They're all pretty much the same. They have a history side and a short cervix side, and then they differ really in the question of whether you're going to use routine universal cervical ultrasound or some selective version of that. Next slide is to have some ease of access to the pharmacies. And to do that, we're working now in advance of this project with pharmacies, with insurance and Medicaid in Ohio to improve the clarity of how this might be done. That turns out to be a little difficult, but our intent is to ask sites to designate a progesterone coordinator, somebody who's the local expert, who can be the focus of who covers what and for what reason. How can I get my patient this medication should not be something that everybody has to remember. Next slide is one version of something. I visited Massachusetts recently and saw that they have done this in a couple different ways, listing various sources and formulations, cost per dose, per course of treatment, etc. Next slide also is in that same vein. I guess that's one of the ones I pulled. The key driver is again, an outcome that's already being measured. We can do it in hand-collected data from the larger sites who have those personnel in place. But overall, what we want to do is move the numbers by reducing the rate of premature birth in Ohio and hopefully the rate of infant mortality as well. We can also look at this from various administrative data sets around NICU admissions and a number of NICU days. Next slide. Here's an example of our latest version of the one-page data form that we're going to ask the larger sites to use to collect their data about outpatients. It has the items listed on the left. When are you due? What's the reason for considering progesterone? Was progesterone prescribed? If so, which kind? Some notion of compliance. And then whether progesterone was not given and why that might have been the case. And then who paid, and eventually a delivery date so that we can track as best we can in sites that are able to do it, the rate of premature birth in hand-collected data. But as before, we'd like to move the numbers. Yeah, go ahead to that next slide. We think we're in a good position to do this because we have been successful so far. We've developed a good reputation in the state. We have a lot of support from the people I've mentioned. Various regional sites have begun to do this around the state. We have a good spirit of collaboration among the OPQC sites and a lot of eagerness to participate in sites that have not. But we recognize the limitations are that this is progesterone, something new. It hasn't been around for a long, long time. There aren't lots of people who have ingrained ways of prescribing it, but they're also a little bit uncertain about it. There isn't a previous quality improvement project that we've seen, and at least certainly not across the state, And probably our biggest concern is that this is a project that's done in a location where people are not, the staff are not used to reporting site-specific data. How many births happened each year, how many women got a cesarean, how many women got steroids are all things that hospital staff are accustomed to reporting. But outpatient office sites, clinics, private practices even are not used to the idea that they're taking care of a group of patients. So we have a rookie staff, and we have a long interval from the intervention to see the effect, and the people who are performing the intervention don't have a chance to see whether there's an adverse outcome or not. And of course, this has to be repeated either every day or every week. So we're, next slide, we're hopeful about this, but we hope in the next year or so we can achieve a reliable birth certificate and stop saying the word certificates, a birth registry system that we can use in the future for perinatal data and quality, that we can sustain our current projects and be successful in getting progesterone started, and two other projects around promotion of human milk use for premature infants, and we hope to develop a neonatal abstinence syndrome project as well. So I hope we've left time for you to ask us questions, and I thank you for your attention.
At this time, I'd like to ask the operator to open the lines for questions.
Thank you. If you would like to ask a question from the phone line at this time, press star then 1. To withdraw the question, star 2. Once again, any phone questions, star 1, please. Again, that is star 1 for phone questions.
Don't everybody talk at once.
I have a question, Jay. Who makes the decision on which formulation patients would get of the progesterone? Is it the prescribing physician, or is it something that you all are planning to use one formulation? I saw you listed the IM version and the vaginal version in the slide.
Right. As your question suggests, there is controversy over which medication should be used, which one's the most cost-effective, safest, etc. And so that's the sort of question for which there is no reliable answer. And therefore, our message to the sites is we want you to do something. You make a local decision, pick a protocol, and what we think most sites will do is to follow the algorithm promoted by SMFM and ACOG, which is to use injectable progesterone for women with a history once a week. They'll have their choice of compounded 17-OHPC or to have manufactured 17-OHPC. And those with a short cervix will have their choice of the same, of either a manufactured product or a compounded product. The one point in all of those algorithms that we are going to push is the use of 20 millimeters as the threshold cervical length. That can be a subject of controversy, but that's one of the few places in the whole algorithm of care where there is pretty strong evidence that 25 is too long and 20 and 15 might be a little too short. So 20 is the right number, we think.
And just to follow up with that question in terms of the indication for short cervix for the vaginal progesterone, what about patients who have physicians who are recommending cerclage, and how does that play?
The algorithms that are been put forth by ACOG and SMFM, notice that OPQC has no algorithm. We promote algorithms developed by others or guidelines and ask that they be adhered to according to local interpretation. Mm-hmm. The algorithms that those two organizations have put out suggest that following women who are receiving progesterone with periodic transvaginal ultrasounds, usually every 2 weeks, is appropriate because cerclage may be a supplemental treatment if cervical length falls below 25 millimeters in a woman with a previous premature birth And it may simply be a choice as well if there's further cervical shortening or visible membranes in a woman who's receiving vaginal progesterone for short cervix. Mm-hmm. As you can tell, there's not a lot of consensus about exactly when a cerclage is to be placed.
Mm-hmm, mm-hmm.
Once again, to ask a question from phone line, star 1, please.
If there are no other questions at this time, we can conclude the conference. I just want to also again remind participants that handouts are available for both presentations. At the top tab on the right upper corner of the screen, the handouts tab, if you would click it and click download, you can download the slides for both presentations. We will also be posting an archive of the video and audio of this presentation on our website.
I show no questions at this time.
Okay. Well, we would like to thank Dr. Peter Shironi and Jay Imes for giving us excellent presentations on obstetric quality improvement initiatives. We would also like to thank all of the participants in this webinar and would like to invite you to join us for our final webinar in this series in August, entitled Neonatal Quality Improvement Initiatives. We would appreciate any feedback you can give us on this webinar series, and we'll be contacting you after this webinar for your input. We hope that our webpage and this webinar series will facilitate exchange of information and promote visibility of perinatal quality improvement activities throughout the country. To help accomplish these goals, we're listing active collaboratives with contact information on our webpage. We encourage you to visit the webpage and to submit information for your regional or statewide collaborative so that you may be included in this effort. You can contact us at the DRH Info link at the bottom of our webpage. Again, the address is www.cdc.gov/reproductive health/maternal infant health/PQC. Thank you again and have a wonderful afternoon.
Thank you for participating on today's conference. You may disconnect at this time.